One of the fall follies in Congress in the U.S. every fall was some guy or lady, but it's been a thought for a number of years. In a number of states, there was a great deal of ambiguity whether direct primary care would be deemed by the law as insurance or not. So now we have clarification at the federal level that direct primary care is deemed to be not insurance, which cleared the decks, if you will, to allow a lot of these benefits, like the health savings account, to begin to accrue to those who subscribe to direct primary care.
Hey, Lee Acey, a host of the Take Charge with HELPcare podcast, and I'm here with Dan Hinman, our co-host, and glad to welcome and introduce Dan, as well as the rest of you, to someone who's become a good friend over these last couple of years, John Kelly from J. Kelly Associates, based in Rochester. I got introduced to John through the Rochester Chamber of Commerce, where we're both members, and one of their folks suggested that we ought to meet because she had just met with John when she met with me for the first time and said, you guys got to talk. We had a great initial conversation and collaboration, and so I'm really glad to welcome John to the Take Charge podcast. And so, John, maybe give us a little bit of your background. I thought it was really fascinating how you originally came from Rochester and ventured out and then came back. And I think it's super relevant to the discussion we're going to have today.
Well, thanks, Lee, for having me on your program. And Dan, it's nice to meet you today as well. Appreciate meeting both of you guys. So a little background on me. Rochester is my hometown. I had an absence of about 40 years while I left after graduating high school to go explore the world, literally and figuratively. Came back to help be a support to my family that was still based here in Rochester. Along the way, and by the way, have worked in healthcare, which isn't that unusual if you grew up in Rochester under the wings of the world-famous Mayo Clinic and Olmsted Medical Center, but worked at several healthcare institutions around the country, like the Henry Ford Health System out in Detroit, the Hammett System out in Pennsylvania, Gunderson, a little bit closer to home here in southwestern Wisconsin, and the Marshfield Clinic. And then finished off my corporate career working with a health insurance company called Security Health Plan. So when I moved back here, I think, Lee, you were probably one of the first business colleagues I met, which was one of the best introductions, I have to say, from my standpoint as well. You're just a very gracious and kind man, and I really appreciate the opportunity to join you guys today.
Well, and I've worked with John on several projects over these last couple of years, and he's been just very like-minded in some of what we're seeing as necessary in the reform of the healthcare system. And it was a few weeks ago when we were discussing the One Big Beautiful Bill, as it was known, that now is the One Big Beautiful Bill Act. But one of the things John alerted me to was that there was a provision in this relating to direct primary care and specifically with health savings accounts. That was very welcome news to me at the time. And so as it was proceeding toward being passed, I was rooting for it from that perspective because I think it could be pretty important. And so now that it has become law, we thought it'd be great to invite John on to talk about the implications. And in this first discussion with him, we'll be talking about the consumer applications for this. And then we'll do another segment where we'll talk about what this means for employers with their health plans. So, John, maybe a little bit for starters, what exactly is a health savings account, and what were the benefits before this new change in the law?
Sure, absolutely. So health savings accounts, known generally as HSAs, they are tax preferenced vehicles. You might call them Archer funds if you're going by the legal name, that allows an individual or a business to make a pre-tax payment contribution into this fund. So it reduces your adjusted gross income. And those funds can be used for any IRS qualified medical expense. And as you use those funds, they are not taxed as well. So they're tax free. So it reduces your adjusted gross income coming into the fund. And when you use them for appropriate expenditures, they're also maintain that tax-free status. So some people go, well, why would I want to reduce my income? That sounds kind of counterintuitive. I like my income. If you know you're going to spend some of your income on things like eyeglasses or dental work or co-pays, things like that, if you can reduce the net cost of that by taking the pre-tax payment, you're saving your marginal tax rate on that investment. For those that are thinking a little bit more grand, maybe they're thinking, how do I shelter income from taxation because I've got a little extra income and I just want to shelter it into an investment vehicle? Health savings accounts are also investment vehicles, so you can actually accumulate assets or wealth in that fund, tax-free accruals over time. You can invest. Most banks or investment houses that set these up will allow you to invest a portion, maybe even a majority portion of your funds into a bona fide investment vehicle where you can get rates of return equivalent to what you would get in the marketplace. So there's lots of reasons people may want to use them. The main thrust for today is to think about it as a way to let your money stretch a little bit further if you're going to spend it on approved medical expenses.
Well, I think the way things have been up until now is that direct primary care membership was not one of those approved medical expenses, right? That it was not possible to pay for a membership in a direct primary care clinic.
Yes, I would say I've been tracking probably direct primary care and the insurance laws for, I would say, the better part of 15 years now. And one of the fall follies in Congress in the U.S. every fall was some guy or lady who is a congressman would introduce a bill called Let's Make Sure Direct Primary Care is Not Called Insurance so people can use their HSA funds to pay for their monthly subscriptions, and every year that would fail. It didn't fail this year, which is kind of the news we want to share with you all today, but it's been a thought for a number of years in a number of states. There was a great deal of ambiguity whether direct primary care would be deemed by the law as insurance or not. So now we have clarification at the federal level that direct primary care is deemed to be not insurance, which cleared the decks, if you will, to allow a lot of these benefits, like the health savings account, to begin to accrue to those who subscribe to direct primary care.
So what's required to have a health savings account, and why does it matter that this is deemed not insurance now to have a direct primary care?
Well, that's a great question. So it's probably one of the easiest investment funds to set up. And in the last several years, I've spent a lot of time talking with individual consumers about health savings accounts. And the first, when you introduce a new concept, people get a little nervous. They don't know, what does this mean? How does it work? And frankly, almost any bank that you bank at will set one up for you, and it takes about 5 minutes. One of the easiest investment vehicles to set up, relatively easy to report on. And you, the consumer, have a choice of how much you want to put into those accounts and when you want to put it in, up to the federally authorized maximums. So if you think about easy to use, it's one of those investment vehicles that's really easy to use. And that's kind of takes the tension out of the room right away. Once you have your funds into your health savings account, most banks will let you set up a debit card function, literally just like a Visa card, if you will, a credit card. And when you go to pay your bills, perhaps you got a copay on your prescription medications, or you might have a copay when you go to see your insurance-based doctor visit. You would just use your debit card. You can also reimburse yourself from a health savings account. So if we think about direct primary care, which is a subscription-based service, you can set up an auto pay function in your health savings account where you automatically deduct from your health savings account your monthly subscription fee to your direct primary care provider. So it becomes incredibly convenient. You make the decision how much you want to deposit into it, and you can set up a payment stream that comes out as easy as 1, 2, 3.
But I believe there's something that with requiring a high deductible health plan as part of a arrangement that enables you to or entitles you to create a health savings account. What are the parameters on that?
Yeah, so we're going to talk a little bit out of both sides of my mouth today because the law has changed. So we'll talk what it is today and then what it will be prospectively. Today, there's a category of insurance-based products called a qualified high deductible plan. It is not just that you have a high deductible, and high by definition would be about $2,000 per person per benefit year. And I know there are many of your clients who probably have high deductible plans where the deductibles are considerably higher than that. It's not out of the realm for people to have deductibles as high as $9,000, $8,000. Qualified high deductible plan not only has that deductible that it's at least $2,000, it also has certain benefit structures where you're paying first dollar coverage for certain types of services. So I have run into clients that have said, well, I have a high deductible, but it's not a qualified high deductible. So legally, they're not entitled to make those health savings account contributions. So that's kind of the rules today. So we want to make sure that we get a little bit specific when we talk about what a qualified high deductible plan is. As a general rule, you have a deductible over a certain threshold. You are then eligible to set up these health savings account investment vehicles, but we just want to make sure we have the right benefit design plan before people go forward. If you change gears and think, where are we going? The additional plans that will be put into high deductible plans will look at dollar limits, generally speaking, that are more generous. So we'll allow more plans to be included and benefit designs to be a little bit less restrictive. It's probably not worth your listeners' time to go into the details today, just to know that it's going to get a little bit easier to set up those health savings accounts and to find qualified high deductible plans that are eligible for them to make those donations into or contributions into.
So we're saying one of the benefits to our patients when this is actually goes into, I mean, it's been approved, the bill's been approved, but what's the date in which they'd be able to use their HSAs to cover their costs in a direct primary care program?
Great. So all of the effective dates for what we're talking about today, and I'm being specific to the direct primary care subscription fees, will take effect on benefit years beginning January 1 of 2026. That said, if you're eligible to set up a health savings account today, there really isn't any reason to delay. And the reason I say that is because there are some consumers that incomes are such that it takes them a little bit longer to accumulate an asset. They may want to think about setting up an HSA now if they have a qualified high deductible plan to bank some cash, if you will, tax preference cash that they can use next year for their subscription to a direct primary care. So there's nothing that necessarily that prevents them from setting up the HSA today. But to expending those funds on direct primary care, we want to wait till the 1st of January of 2026.
It's a really nice benefit.
Yeah, so you also talked about, when we had a previous conversation, you mentioned something about Affordable Care Act tax credits and how those are going to be modified somewhat in the coming year. Could you talk a little bit about that, the broad scope of that?
Yeah, so probably for most people who have individual Affordable Care Act policies, so we're not talking about the whole scope of the law, but I have what we call, if you're in Minnesota, we call those marketplace plans. The window of time to enroll in those plans has narrowed considerably because of this act, and that will take effect after October of this year. So in 2024, we had basically from November 1st until January 15th to enroll in a marketplace plan. And those marketplace plans, if you enroll prior to the beginning of the year, would start January 1. After January, they would start February 1. With the new law, we have a 1-month window basically to enroll in a marketplace plan. So we're taking 10 weeks of activity and we're compressing it into 4 weeks. So we want to think ahead a little bit. If we're going to go that route, we don't want to assume that we have just the same amount of time this coming enrollment season as we had last year. So that's one big difference for the consumer. The other big difference is in the past, we used to have what we called auto renewal. So let's say that, Lee, you had a marketplace policy for your family. If you liked your policy and you were thinking you're going to keep it the next year, it just automatically renewed. You didn't have to do anything. There was no new application process. You didn't have to check a box. There was no fee, nothing. In this coming fall enrollment period, you will have to take a positive action. You'll do something. We don't exactly know what that's looked like because the law just passed, but we're going to have to do something to renew your policy. We may have to provide some additional documentation. We'll probably have a small application fee, like I'm guessing in the range of about $5. I would call that a nuisance fee. It's not a huge fee. And then we'll renew your policy for January 1. So those are some important differences. The other one I think that's really important for the consumer to know isn't embedded in the law, but it's based on what I see going on in the trends in marketplace policies. If we want to talk about Minnesota specifically, where I think most of the HELPcare clinic clients reside, marketplace policies in Minnesota are looking to go up on average somewhere in the range of 17% for 2026. That's a pretty big jump. It has nothing to do with anything other than the entire risk pools will be changing and there's recoupment costs and so forth. But what that means to the average consumer is if you had a richly benefited plan, you might be looking for a skinnier plan and a way to cover your basic medical needs. And this is where I think it really becomes attractive for direct primary care. So if you had a silver plan or a gold plan in the marketplace in Minnesota, you might give thought to moving to what's called a bronze plan. So a little bit skinnier benefits, a lot less on the premium side, and supplement that with a direct primary care subscription, and on net come out financially ahead. Not speaking at all to the benefits of joining of a direct primary care in terms of the relationships with the primary care doctor, but just financially, you're better off. And you can pay for your subscription fee with pre-tax dollars. So it's those things start to come together. It begins to make marketplace policies, health savings accounts, and direct primary care look much more attractive in 2026 than they might have looked in 2025. Hopefully that
sense of one.
made sense.
That's super helpful because, so this is my true confession as well. One of the things is that John Kelly is the one who's helped me get my marketplace plan personally for my wife and me up to now. And up to now, we haven't had one that is eligible for an HSA because we have a direct primary care membership. And so it's not, we haven't been eligible to do that kind of thing. I noticed that when we were signing up, though, that the HSA plans seem to cost more than a comparable one. And is that because there's some that's passed through to the HSA, like that there's some amount that gets deposited in HSA, or is that just, what would be the explanation for that?
In the MNsure marketplace, in the neck of the woods where you're at, there are fewer health savings account eligible plans than there are non-qualified high deductible plans. And the pricing of those plans has a lot more to do with the benefit design. Remember I was telling you earlier that they have, in addition to a deductible, they have to have a unique benefit design. It has to do with those benefit designs and how they negotiate with the provider networks than it has to do with anyone taking funds and putting them in the HSA. So what the insurance carrier does has no control over your contributions to the HSA. That's a personal decision you make. But the plan design from an actuarial standpoint, when you have limited products, actually makes those products kind of look sometimes a little more pricey than the other ones.
Okay. So what are the couple related questions? Do we know when that 1 month period is going to be for the signing up for the ACA plans?
It'll start November 1 of 2025.
Okay.
And we'll have about a month to complete the process.
Okay.
So, if you have nothing to do over Thanksgiving, we should hang out together and re-enroll you and your wife.
Very good. Very good. And what's the maximum that people can contribute to an HSA? And does that have to be, do you have to decide that right when you sign up for the HSA? Or is that something that you can make contributions through the year?
Right. So, you can make a decision. So, the first big decision is whether you are married or not married. So if you are married, you can basically double your contribution to a health savings account if you have an individual family policy. And if I'm okay using your example, which you do, so you can actually make close to $8,000 per year contribution to a health savings account. If you happen to be a more mature member of the marketplace. So think someone who is getting a little bit closer to retirement, not that you have to retire. There's what's called a catch-up contribution to a health savings account. So you're allowed to go over the federal IRS maximum and make a catch-up contribution. So you can actually make another $1,000 a year contribution. What we don't know yet is what the contributions for 2026 will be. So we're still waiting for the IRS ruling on what the 2026 guidelines are. So I'm kind of quoting what you could do in 2025. The other part of your question is, when do I have to make that contribution? And the answer is pretty much whenever you have a qualified high deductible plan. You can do it as one lump payment. You can spread it out over many months, and you even have until you file taxes the subsequent year to pay for the current year.
Sure.
So you could make contributions in your case. Let's say you want to do this for a 2026 plan. You could start making contributions in January of 2026, and you would have all the way until April 15th of 2027 to complete your contributions. So you can spread it out, basically over about a 15.5-month period of time if you need to.
So it's essentially like an IRA in that perspective?
Yeah, very similar.
That's the way I understand it.
Absolutely.
One of the things I'm curious about too, John, is I've been reading that this enacted bill might reduce the number of people that are eligible for Medicaid moving forward.
Indirectly, it might, not directly. So the core rules of Medicaid essentially remain unchanged. So Medicaid in most areas of the country is a income, what your income is, and asset, how much things you own, asset-based test. So if your income is low enough and you don't have a lot of investments or you don't have other assets, you would qualify for medical assistance or Medicaid. Those rules are basically the same. The income limits index every year, which means that the threshold for qualification on an income basis will change based upon inflation, and the assets may change every year as well. What changed in the One Big Beautiful Bill Act, we got to come up with a better name than that. Although I probably shouldn't have said that out loud because I know some people like it an awful lot. The OBA Act is that how you keep your medical assistance has changed. So one of the key things that people should be aware of is that in the past, once you qualified for Medicaid, medical assistance, there was what's called a redetermination. Are you still eligible kind of question. And oftentimes you would do that once a year. During the pandemic, it wasn't done from 2020 until July of 2023. So there was a long period of time where you didn't have to be tested as to whether you were eligible for medical assistance or not. In the new rule that passed, the minimum requirement is every 6 months. So you must be redetermined or renew your eligibility every 6 months. And states have some discretion to increase the frequency of that. One of the key variables right now is what's called the work requirement. It's a little bit of a euphemism because it doesn't mean you actually have to be working, but you could be working. You have to work about 80 hours a month. So essentially at least a part-time job to maintain your Medicaid eligibility, or be doing volunteer work of an equivalent time in case you are unable to work, or be in what's called an exempt category. A certain exempt categories like I have disability, I'm a child of a single mom, I'm newly pregnant, those types of things. You don't have to do that renewal. But if you're otherwise able to work and not exempt, you would have to renew your eligibility every 6 months. Those new rules, depending on how frequency they happen, we believe will reduce the enrollment in Medicaid across the country substantially. So if you look at how the law passed, it's based on the new rules, not so much qualifying, but how you keep the plan. And because that may cause people to lose their renewal, we think the total number of people enrolled in medical assistance will fall starting sometime in 2026 and going forward.
So thanks for explaining that. I guess what I was considering was if I was an individual on Medicaid and I wasn't able to requalify after some review, then maybe a direct primary care plan could be a really nice alternative for me, right?
For sure. I mean, it certainly could. And I don't think even if you had medical assistance, there's nothing that would prevent you from having a direct primary care provider as well. I think probably, Dan, to your point, the bigger issue is the affordability. So if I can't afford direct primary care now, it's not likely I'll be more able to afford it because I just happen to lose medical assistance. Right? If in
Right.
fact it stimulates people to increase their productive work hours, their income would go up. So that could have a positive effect on being able to join a subscription service.
But also, if you're getting medical assistance, people are getting that free. Like, so right now, there's part of the reason people don't sign up for a direct primary care membership is because I'm getting this other care through Medicaid, medical assistance for nothing. Like I'm not paying anything for it. And so paying anything for that is like that it's another expense that for something that I don't have. Whereas if somebody does lose medical assistance and if they still want to have health care, it's not necessarily more affordable than it was, but it's also you don't have the free option, and so you might decide that direct primary care might be a better way.
And maybe this is a small market and I'm getting into the weeds a little bit here, but suppose I'm a parent and I have a kid who's going through a rough time and they don't have insurance, and maybe they have low income. Maybe I'd want to help support that kid by sending them $150 a month or whatever the monthly rate is for direct primary care and help them get the coverage that they could really benefit them.
Yeah,
Just as a scenario.
For sure. No, that makes total sense. Right now, under the Affordable Care Act, any direct dependent, so a child who's under 26 years of age, can still be covered on their parents' policy. But the truth of the matter is some of those payments, those premium share payments that the parents have to make, may exceed the cost of a subscription service to direct primary care. So that's a valid point that you're making, Dan. My sense of things in the state of Minnesota, so I want to bring it home to most of the listeners for your podcast, is not so much the medical assistance patient mix, if you will, those beneficiaries, but there's a different category in Minnesota called Minnesota Care that I think is the one we really maybe ought to spend a few minutes chatting about today. So Minnesota is one of 40 states around the nation that created what's called the Medicaid Expansion Program under the Affordable Care Act. So that means that if you're above the income level for medical assistance, but below 250% of the federal poverty level, you can qualify for a Medicaid-like program similar to Medicaid, that the premium is on a sliding fee scale, and so are your copays and deductibles and so forth. In Minnesota, that's labeled Minnesota Care. It's only based on your income. It does not have anything to do with your assets. So if you own your own home and perhaps you took early retirement, you're not ready for Medicare yet, the senior program, if you will, you might have reduced your income enough where you qualify for Minnesota Care. Okay. If you do that, that's the group I think we might see a lot of movement on in 2026. So I'm way out ahead of what the state of Minnesota regulatory authorities are saying, but it seems logical to me that with the strain on the Medicaid budget at the state level because of the One Big Beautiful Bill Act, that we should reasonably expect to see some changes in how premiums and deductibles affect those on Minnesota Care. Okay, so if you didn't have a premium on Minnesota Care or you had a modest one, it might become a little higher. If you had low copays, they might become a little more. And we're kind of creeping into this scenario where it begins to make more financial sense, right, to consider looking at a direct primary care option. Okay, and a lot of the people on Minnesota Care, because they're generally speaking smaller business owners or semi-retired and looking at how much income they take each year, will be flipping between I'm in Minnesota Care, meaning my income is low enough, and I'm out of Minnesota Care, meaning I'm in the marketplace. And so I think some of that we're going to see going on in the fall months leading up into the new benefit year. And that's where I suspect we'll see more movement in the consumer market going after programs like direct primary care at HELPcare Clinic. That was probably way too technical an answer, but
that's actually really great. And what it highlights for me is that I think we're going to have you be the first person who's on 3 times this year with us.
Oh my gosh! Please,
so we're going.
Don't torture your visitors with that. That would be terrible.
So we're gonna next time we're gonna talk about sort of the implications for business owners and for employers and how some of these changes might make a difference for them. But I do think that then a couple months from now, as these things are starting to get sorted out, as some of the regulations are getting written both locally and nationally, it'd be great to have you back with an update as we're heading toward that open enrollment season so that people can have a sense of what this might mean for them.
Well, I'd be happy to come back. If for nothing else, to get to see you and Dan again, that would be fantastic.
Well, very good. Well, next time, as I mentioned, we're going to be talking about the business implications and for employers. And so just invite people to join us again next week for Take Charge with HELPcare. Thanks for joining us. If you enjoyed this episode, be sure to leave a comment or a review and to subscribe on Spotify, Apple Podcasts, or on YouTube. And also to share Take Charge with HELPcare with your friends and on your social media channels. At HELPcare, our passion is helping people take charge of their health and their health care, helping employers take charge of their health plan expenses, and helping physicians and other practitioners take charge of their healthcare careers. Learn more about the HELPcare Clinic difference at healthcare.health.